Hello, let's learn about urine tract infection and acute febrile illness. In UTI, it can present as uncomplicated UTI, prostatitis, complicated UTI, pyelonephritis, or upper UTI, or catheter-associated UTI. Uncomplicated UTI presents with burning, micturition, urination, increased frequency of micturition, urgency, suprapubic discomfort. Then there is no fever. Fever indicates systemic spread. In prostatitis, we see fever, pelvic or perineal pain, history of perineal pain whenever intra-abdominal pressure is increased. Then we have complicated UTI, where you see UTI with stones, obstruction, indwelling catheters, congenital anomalies, immunosuppression, neurological urine retention. Then we have pyelonephritis, where we see fever, chills and rigors, flank pain, renal anger tenderness, and toxic appearance. Then we have catheter-associated UTI, wherein we see signs and symptoms of UTI after 2 calendar days of catheter insertion. Then we have acute simple cystitis in females when we do diagnostic tests like urine dipstick or microscopy or urine cultures. Then we have prostatitis or pyelonephritis or complicated UTI when we do urine dipstick or microscopy and urine culture and sensitive testing if leukocyte ester is positive for more than 10 pastilles per microliter. What are the indications for urine cultures? It is fever, then alteration of consciousness, fever with catheter, recurrent UTIs and all infections. What are the signs and symptoms of UTI? It is associated with male sex, chronic obstruction, chronic renal insufficiency, nephrolithiasis, and poor control diabetes, pregnancy, and immunosuppression. Do not send the urine specimens as routine just in case samples. It should be associated with some clinical signs and symptoms. What are the indications of urine cultures? Pregnancy, preoperative evaluations, neurogenic bladder, spinal cord injury. Then when not to send urine cultures, in asymptomatic patients, cultures should not be sent. Then outpatient females with simple lower UTIs, then if urine is odorous or cloudy or discolored in the absence of other localized signs and symptoms, urine analysis shows pyruria in the absence of symptoms, then just urine culture just for documentation should not be done. Unnecessary sampling and unnecessary leads to unnecessary antibiotics. For the urine culture, a clean catch midstream urine sample is the preferred method. Initial flow of urine from the first valid urine of day should be avoided. It is indicated for urethritis or prostatitis. Single catheterized urine is indicated for morbid obesity, elderly, and bladder incontinence. Suprapubic aspiration should be done in urethral structures or bacteria in infants and children. Indwelling catheter after catheter clamping. So these are the specimen collected for different. What's the volume? Minimum volume should be 1 ml. Fungi it is 3 ml. Mycobacteria 20 ml. 3 consecutive first order specimens is required for mycobacteria. For Chlamydia trachomatis is 10 ml. Paracyst 10 to 50 ml. Anaerobes is 1 ml. Full specimens 24-hour collection is required for Schistosoma hematobium, Trachomas vaginalis, tophozoites, and Onchocerca vulvaris microfilaria. For this 24-hour collection is required. Urine culture transport should be done within 2 hours. If delay of more than 2 hours is there, then refrigerate within 10 minutes of collection. If transport is to a distant site, then use an ice box. Urine preservative can preserve the urine up to 24 to 48 hours during transport. What are the unacceptable specimens for urine cultures then? 24 hours urine specimens from bed pans or urinals or Foley's catheter tip, urine transported in broth, grossly bloody samples, diluted samples from urine bags, then sent to sediment from clean catch samples, anaerobic cultures. Anaerobic cultures especially are not acceptable specimens. And what are the 4 moments of antibiotic decision making? Does my patient have an infection that require antibiotics? Have I ordered appropriate cultures before starting antibiotics? What is the empirical therapy should I initiate? A day or more has been passed. Can I stop the antibiotics? Can I narrow the antibiotics from IV to oral or broad to narrow? What duration of antibiotic therapy is needed? So these are the key. These are the 4 moments wherein this is required during antibiotic decision making. That is, the first moment is make the diagnosis. Second, the cultures and empirical therapy. Third is stopping or narrowing the spectrum of antibiotics, and then duration, determine the duration. Then second moment is also was about urinalysis and cultures. Send the urinalysis and urine culture when patients have symptoms of UTI. Do not send the cultures for foul smelling urine routinely on admission, routinely before or after catheter change as a part of fever workup or as a test of cure. Ensure that the cultures are collected. The positive urine analysis indicates more than 10 WBCs per field. Leukocyte ester is positive. Nitrites reduced to nitrites, indicating bacteria in urine. Positive urine cultures can indicate if there is no catheter and the count is more than 10,000 to 1 lakh. Catheter, in case of catheter, if the colony count is more than 1,000 of a urinary pathogen. So often blood cultures whenever you suspect pyelonephritis or urosepsis. The second moment is about the empirical therapy. Oral therapy is preferred. Avoid giving cephaloxone or other IV options. Avoid fluoroquinolones. No longer it is the first line of therapy. Option to consider for UTI is the first line recommendations are nitrofurantoin or cotrimoxazole. Or second line options are oral cephalosporins. For any UTI, look at prior urine culture information to get. Moment 3 is de-escalation and IV to oral conversion. Patients should be treated for 3 to 5 days with relatively narrow spectrum of agents. So there is not often an opportunity to de-escalate. If you start antibiotics for cystitis and subsequently determine alternate diagnosis, stop antibiotics. Then moment 4 is the duration. Nitrofurantoin duration is 5 days, cotrimoxazole is 3 days, cefaclor is 5 days, ceftriaxone is 3 days, and cefaclor is 7 days. So the duration needs to be adhered. Then pyelonephritis, moment 2, empirical therapy. The fluoroquinolones or cotrimoxazole are preferred given excellent penetration into the kidney. It can be given orally, given excellent bioavailability, but consider local E. coli resistance. Second line therapy for pyelonephritis will be ceftriaxone. In case of allergy, then gentamicin or aspirin. Pyelonephritis, for the moment that is de-escalation or IV to oral conversion is recommended. If susceptible fluoroquinolones or cotrimoxazole, then continue or convert to this oral agents. If resistance, then consider an oral cephalosporin. Regarding duration, fluoroquinolones duration is 5 to 7 days for pyelonephritis, cotrimoxazole 10 to 14 days, and oral cephalosporin is 10 to 14 days. Regarding the moment to that is urinary culture, the same general approach as with non-COTY. For patients with chronic catheters should be removed before cultures are obtained. Patients often have pyruria in the absence of COTY. Positive urine cultures more than 1,000 of urinary pathogen is indicated. Then empirical therapy, remove the catheter whenever possible. Empirical therapy based on severity, location of infection, and information from prior urine cultures if available. Moment 3, that is de-escalation and IV to oral conversion. If susceptible to cotrimoxazole, then can continue or convert to IV, convert from IV to oral. If treating or severe infection, can consider oral ceflox or levoflox. If resistant to the agent, then consider oral cephalosporins. If moment duration, if catheter is removed in a female patient less than 65 years, and no upper tract urinary tract infection, then 3 days of duration is recommended. Prompt resolution of symptoms, then 7 days. Delayed response, then 10 to 14 days. Other complicated UTIs include UTIs occurring in the presence of urologic abnormalities such as those described in the previous slide, that is UTI in pregnancies and other such. The management of the underlying associated process must always also occur whenever possible. That is relief of obstruction by nephrostomy tubes or stents or transurethrization of prostate. As with catheterized urinary tract infection, antibiotic selection depends upon the extent of infection and severity of illness. Duration based on clinical response and timing of inciting process. Prompt resolution symptoms and resolution of the underlying abnormality takes about then the duration 7 days of therapy. Delayed response, then the duration comes to 10 to 14. Improve the prescribing for sensory testings and UTI at your hospital. Intubation can occur both at the time of urine culture is ordered and after the urine cultures are available. Do not order the urine culture in absence of signs and symptoms of UTI, including patients with catheters. Work with the lab to determine from where and why urine cultures are being sent. Consider reflex testing protocols. Develop tools in the emergency department to prompt in the electronic health records to prompt providers to document indication for sending a urine culture. Ask the patient if he or she is having urinary symptoms before initiating antibiotics. Ask the colleagues why the urine culture was sent. Develop and follow the guidelines for treatment, escalation, and de-escalation. So, what are the take-home messages? Send urine cultures only when you suspect UTI. And it should not be sent in absence of symptoms. Asymptomatic bacteria is common, particularly in older people, and should not be treated. Uncomplicated cystitis should be treated with a short course of antibiotic. UTIs in men are rare. 7 doses of courses of therapy for uncomplicated pyelonephritis if we can use a fluoroquinolone. But increasing rates of E. coli then is a concern. There are many opportunities for stewardship in urine cultures and optimization of UTI therapy. Thank you.